Namaste. We're back with another episode of Resusc-i-Station, the official podcast of the IRCF. Tune in to get the latest about Resusc-Station from around the world. I'm Dr. Megha Venkatesh, and joining me is our co-host, Dr. Manchit, and together we welcome you again for today's podcast. We're excited and humbled to have one of the biggest names in the field of resuscitation of children, Dr. Vinay Nadkarni, Professor of Anesthesiology, Critical Care Medicine and Pediatrics. He's also the founding director of the Center of Simulation, Advanced Education and Innovation, and Academy for Resuscitation of Children at Children's Hospital of Philadelphia. Dr. Nadkarni served as the president of the Society of Critical Care Medicine 2023 to 24 and has a lifetime of commitment to pediatric emergency, critical care and resuscitation science, education and practice. He is also a prolific research scientist with more than 800 peer-reviewed manuscripts and 35 book chapters to his credit, and has been recognized by numerous Lifetime Achievement Awards by the AHA, ILCOR, Citizen CPR Foundation, AP, and SSCM. Sir, it's an absolute honor to have you share your knowledge with us today, sir. Thank you for joining in.
My pleasure, Megha.
Sir, over the last couple of decades, there have been substantial improvements in outcomes after pediatric cardiac arrest. What are the key factors that has brought in these changes? And even one of your research articles talks about the role of CPR duration in pediatric CPR and its effect on survival and neurological outcomes. What was the inference there and the current recommendations like?
Megha, I think the key thing that has really pervaded the improvement of outcomes from 13% to almost 50% survival with favorable neurologic outcome over the past 20 years has been simple interventions with high quality CPR, fast, push hard, minimize interruptions, don't overventilate, but having a quality improvement approach with feedback, preparation, feedback during resuscitation, and after event debriefing that has improved the quality so that the standardization of pediatric CPR has been accomplished, bringing low performance to good. And then in selected circumstances, special resuscitation circumstances, being able to deviate from the standard thoughtfully to achieve better outcomes. So if a patient presents with neurologic injury, trying to emphasize the brain perfusion with higher mean arterial pressures. If the patient presents, as most children do, with respiratory failure, trying to mimic the oxygenation, ventilation goals that they had before arrest to achieve excellent outcomes. So it's preparation, selecting the right targets, achieving high quality resuscitation. You mentioned duration of CPR. Over time, duration of CPR has become less associated with good neurologic outcome because the quality of CPR and the appropriate of transition to, say, eCPR or extracorporeal CPR in the in-hospital setting has become better and more appropriate. So the influence of duration of downtime or poor flow during CPR has been minimized.
Yes, sir. That's been quite an evolution from crude times to...
Quite an evolution.
So moving on, as a mother of an infant myself, neonatal or pediatric out-of-hospital cardiac arrest sounds like the biggest nightmare. So do you think it is important to teach the nursing mothers or the caregivers the importance of sudden infant death syndrome or the need to learn CPR?
Yes, of course, I believe everybody should learn the basics of CPR and how to activate an emergency response in or outside the hospital. But because the risk for sudden infant death, apnea, airway obstruction, and cardiac arrest is highest in that early infancy, it is very important that very simple measures about the placement of the child in the bed to avoid sudden infant death syndrome, the recognition of irregular or impaired breathing, and the notation to call emergency medical systems and initiate rescue breathing and or chest compressions if it's needed is really important. And you and I both know, Megha, that in this generation, the teachable moment, people Google, go to YouTube, they get their information right before they need it. Well, of course, the birth of a child is expected event and a big event in our lives. And so it's very easy for us to target the training to that teachable moment where that mother is most likely and that family member is most likely to learn the skills of CPR right before they go home with their baby.
Yes, sir. That's very thoughtful. I was just thinking about it as I was raising. So this, whenever we have a baby sleeping next to us, we have all the wrong things coming in. So we want to protect the baby first. Nothing else comes. So I think
And people will come together around a baby.
Yes.
Sometimes they won't come together around their parent or grandparent, but they'll come together around the baby.
That's true.
Yes, sir. I mean, being overprotective, but in the right direction always serves the purpose.
And nowadays we have ChatGPT and all the AI tools also for them to search.
Yeah.
Yeah.
It's a new generation.
So true, sir. Then probably the next question is revolving around the same. Recent years have seen revolution in the field of resuscitation medicine. So we're living in the era of groundbreaking discoveries, AI assistants, novel gadgets, monitors, which are enticing for the younger medical trainees. But would you like to stress on the importance of the basics and how fundamental is it to build their practice, sir?
Yeah, I think we have seen definite benefits, doubling to quadrupling the survival outcomes when very simple things, chest compression only, near continuous chest compressions of appropriate depth rate. These simple things have made a big difference in survival outcomes. The gadgets, the AI, they're going to be important. It's going to evolve. But thus far, let's do the simple things right, the right time, right place, right now. But there are some areas that are really engaging that are appearing to make a difference. So for instance, when we call emergency medical systems, 911, whatever your local number is, we're discovering that the dispatcher, the telephone dispatcher for CPR can make a huge difference. And there's a lot of work going on now to use AI and advanced techniques to analyze the call and the sounds that are happening at the bedside to improve the decision support of the telephone CPR dispatcher. Perhaps this is the area which is most likely to benefit from this type of advanced technological breakthrough very soon. So I'm really encouraged by the early findings with AI in that area. The second area where I think AI and the advanced technology is making great leaps forward is in prediction and early detection of life-threatening events, clinical deterioration. Whether it's in the home with a smartwatch, etc., or whether it's in the hospital with the monitoring systems that can integrate an alarm. And now we just have to make sure that we don't have too many alarms and suffer from alarm fatigue or false alarms. But the technology is moving fast. And I think those are two areas where technology will blossom very quickly.
The novel techniques can probably only assist or refine, but how we manage solely depends on the basics.
And I like the simple things matter.
Yeah.
It's first principle thinking, right? I love that.
But Mega, don't forget that there are some things on the horizon. So for instance, drone CPR, drone delivery of AED, or the drone actually landing on the chest of a patient on a golf course or in the field or at the accident scene and being able to land and deliver compressions. These are things that are in the near future that are being worked on, particularly geolocation of the cardiac arrest and dispatch of the needed equipment, whether it's a tourniquet to a road traffic accident to stop the bleed, or whether it's an AED defibrillator to shock a sudden cardiac arrest victim. These are things that we can see now in our eyes that are coming, that are not quite here, but may improve the delivery of simple life-saving procedures, chest compressions, defibrillation, these simple things that we can now get to the patient much, much faster than we ever could before.
Absolutely, sir. We're evolved beyond imagination, I can say. Moving on, sir. In the 8th annual review of ILCOR recently, there were some treatment recommendations summarized with respect to pediatric and neonatal life support. A lot of debates going on with regards to the blood pressure threshold post ROSC, prophylactic anti-seizure treatment, be it about the ventilation rate of advanced airway intervention in pediatric cases, or role of cord clamping in neonatal resuscitations. Can you throw some light on these latest recommendations that would educate our practitioners here, sir?
Well, I think even though we're forced to make recommendations, pro or con, just these interventions that you're talking about. In pediatrics, we're still working on relatively low quality of evidence because the randomized controlled trials are really still lacking. So it's a combination of retrospective observational studies, common sense, and putting together a sort of adaptation of an interpretation of the adult studies. Let's take, for instance, the tools for ventilation for out-of-hospital cardiac arrest. Currently, we don't know if bag mask ventilation, laryngeal mask or supraglottic airways, or endotracheal intubation are better. The current thought is that likely out of hospital, because of the rarity of pediatric cardiac arrest being encountered by most out-of-hospital practitioners, that bag mask ventilation or supraglottic airways are likely more successful in children out of hospital. We don't have any such studies in hospital because both and the trained providers are generally available in hospital who are practiced in endotracheal intubation. You mentioned cord clamping and even T-piece ventilation. These are the hotly debated items in neonatal resuscitation, where the one thing that came forward this time was there was some emphasis previously on these prolonged ventilations to try to aerate the liquid-filled lungs of the newborn, of 10 to 30 second duration of positive pressure. But these have not proven in randomized controlled trials to be beneficial, so have not been adopted. In the post-arrest area, there's some very interesting studies that look like we should be moving towards a higher post-resuscitation blood pressure, mean arterial pressure, that is higher than the 5th percentile, which was previously recommended, and maybe 25th or 50th percentile, so at least greater than 10th percentile, but a higher perfusion pressure for the brain in the post-resuscitation period appears to be associated with better outcome. We're lacking direct interventional trials, so there still is the possibility that there's an association of better blood pressures with better outcomes, but it may not be causative. It may be because we were able to achieve better blood pressures, they had better outcomes. So the current recommendations are to target higher blood pressures post-arrest. And we have some studies that are now addressing the duration of cooling after cardiac arrest. Normothermia, hypothermia, the age-old question that comes and goes. Right now, some benefit for out-of-hospital cardiac arrest for therapeutic hypothermia, but the duration of cooling is unknown. So the P-ICE-CAP study is about halfway through and is collecting data with an adaptive trial to try to look at the duration of cooling, just like the adults are doing with the ICE-CAP study for adults.
Interesting, sir. So, and what about the anti-seizure treatment for better neurological?
So the treatment of seizure appears to be important, but the prophylaxis of seizures after cardiac arrest is not currently recommended. So just giving the medication, because every medication has a benefit and a risk, and it is not clear that the benefit of prophylactic anti-seizure medications after cardiac arrest, nor antibiotics, are beneficial and outweigh any risk of the anticonvulsant therapy.
Makes sense, sir.
Dr. Nadkarni, I'm having a sort of a fanboy moment here, and we're so excited to have you here. So let me begin with my end of the questions. I was casually perusing through the plethora of work that you've done, and I was pleasantly surprised to see a paper with an Indian background, the ABC pilot program, which I understand was targeted at saving lives of road traffic victims from bleeding out on scene. So can you dwell more on this and tell us how has it taken off from here?
Well, it's really an exciting project that was initiated by Indians, the PD Stars program, a simulation group, and Geeta Ramachandran, and the Hyderabad group with GVK EMRI, the Emergency Medical System, and Dr. Ramana Rao. This was a project that identified the busiest road traffic corridors in and around Hyderabad and recognized that 40% of the deaths were occurring due to life-threatening bleeding that was not managed at the scene or en route to the hospital. So 40% preventable deaths from life-threatening bleeding, usually two-wheeler, three-wheeler, extremity injury with significant bleeding. So what we undertook was we made a very simple, inexpensive program and materials, a kit, and simple training. And we had the medics from the GVK MRI system go out to the road traffic sides, to the store owners, to the shop owners, to the rickshaw drivers, to the people who lined those corridors where the accidents were occurring. And they trained 1,000 of them at their T stands with very simple materials. And over the next year, the implementation of that program was able to demonstrate the 2 saves where they used the techniques and the materials they used to intervene in a road traffic accident bleeding incident. And so this was very important. So where did it go from there? This information was very important. We translated to the 16 high schools in Hyderabad area, and the school children competed with each other to learn the ABC, Active Bleeding Control Program, Stop the Bleed. But in addition, they demonstrated a multiplier effect. They were instructed to go home and teach 3 other family members, mother, father, sister, brother, aunt, uncle, grandpa, or their housemates, how to stop the bleed. They were followed by their instructors with WhatsApp. So they documented correct training and then back demonstrated that they could indeed place a tourniquet, use pressure, identify life-threatening bleeding, and call 108 in an emergency. And now that has now traveled to Bangalore. It's being instituted in Delhi, now going to Kenya, now going to Ghana. So this program is transportable and can be trained virtually because it had to be trained during COVID as well. So it was converted to an online WhatsApp supervised course that was asynchronous for training. So this is very exciting because now the World Health Organization is starting to pick it up and include this type of training in their basic and emergency and critical care course that they are launching in sub-Saharan Africa and considering to launch in the northeast of India. Really exciting stuff.
It's a proud moment to know that an Indian program is being adopted world around. And a common theme in all these is the use of school children. I think Dr. Bern Botiger and the European group was talking about how important children are in resuscitation.
Kids save lives.
You must be proud as a pediatric anesthetist to know that children can have this sort of impact.
Well, we learned quite a lot in the United States. One of the things that made seatbelts very effective was when they focused on teaching the children not to move the car until their parents had their seatbelts on. The children were the ones who were forcing the parents to put their seatbelts on.
Reinforcement.
And they would do it for their children, but they wouldn't do it because of the laws or the cameras or anything else. They did it when their children said that don't move the car until you put your seatbelt on. That's what I learned in school.
Another thing that children love are games. In the last episode, Dr. Andy Lockie, he introduced me to a beautiful gaming app called Lifesaver. So it lets you play around with different resuscitation scenarios. So that is a take on gamified learning, which I believe is trending nowadays. Yes. What do you think about gamified learning and how effective is it for resuscitation training?
Wow, you ask a really, really good question. Gamification is really good because it excites, it engages, and it really brings people to resuscitation. So one aspect is perhaps the number of people trained will accelerate. And in fact, if we can embed resuscitation training into standard games, we could make a big impact because people would almost be learning it without coming to a course for the purpose of learning it, right? It would kind of be just by happenstance. But there are some cautions. We don't yet know whether the learning that occurs during gamified, augmented, or virtual reality, etc., whether this translates into improved action and outcomes. We know they enjoy it. We know that they can learn the cognitive details they need to know, but it's not yet clear how excellent it is at teaching skills. And we speculate that it will be very good at teaching team behaviors because with avatars, with our gaming, we're used to having people enter, exit, etc. And to manage teams remotely, asynchronously, we can pretend we're in the same room and learn the skills of communication, the skills of teamwork, and the skills that are needed in order to improve the quality of resuscitation. So there's a lot of potential, but I'm not sure that we have the data yet to know that gamification, AR, VR are as effective or more effective than our standard training.
So moving on from games to sports, are you a fan of cricket or football?
Oh my goodness. Unfortunately, I'm not too knowledgeable about cricket, but I'm very interested in both American football and European football. In fact, the Philadelphia Eagles are in the Super Bowl next 2 weeks. So
Go
I'm very
Philly.
proud. Being from Philadelphia, it's my team. But we're learning a lot from coaching, training, and the professional sports groups. And the other thing we're learning from them is not just about teamwork and coordination, but also about resilience and mental health and how to, in a high performance, high stress resuscitation, how do we keep our practitioners fresh, motivated, and not too critical of themselves? Because even the best resuscitations, 50% or more of the time, we're going to have bad outcomes, not related to bad performance, but because the condition of the patient may not be responsive to resuscitation techniques.
I'm so glad you brought about the theme of resilience. WFSA has emphasized workforce well-being this year. And one of the things that they mentioned there is about how we can be well by being resilient. So that's a beautiful theme from sports. I asked about sports to know what happened down in Italy, the Italian pediatric sim wars, as they call it. I'm sure our listeners will be intrigued to know what that is.
So I have to tell you, we changed the name from sim wars to sim games because wars has a negative connotation, right? Especially in the world these days. But what we've done now for now 6 years is we have made challenges gamified and brought together teams from each of the pediatric residency programs, 36 in Italy. They come together on 1 week in September near Rome. And each one of them, because they didn't have enough mannequins at their own places, they would rotate mannequins from residency program to residency program around Italy during the year, training on 12 pediatric advanced life support resuscitation scenarios with a team. So they got very good at their resuscitation scenarios. Then they come together and they get sorted into Harry Potter houses of competition, and they compete within their house. And the winner of each house then comes together in the semifinals and the finals, and they have a simulation games, almost like an Olympic event across Italy, with a lot of spirit, a lot of fun. The purpose is really training. It's formative, but they have a lot of fun, and it's a lot of pomp and circumstance, and it emerges with a winner, and then they merge teams and they perform together so that they then get out of the competitive spirit and more into just about the training. But it's really a great fun event, and now it's evolving. So we're doing it now in Argentina, Colombia, and we're starting in Ghana in sub-Saharan Africa. Next will be India.
I was going to ask you the same. Have you seen any Indian teams in them?
We haven't had any luck with getting the Indian teams yet, but Ibor Jacob James, the folks at CMC Vellore, those at PGI and at Ames Delhi, they're all coming to participate so they can observe, and they're talking about having a competition and a boot camp in India itself. So we'll get there.
Really exciting. I must tell you, we did something similar when you talked about Harry Potter. For our Regional Anesthesia National Conference, AORA, we did this experiment called Ganglions of Fire, which was based on Harry Potter.
Great.
That reminded me of that. So exciting this is. So you played key leadership roles in various national and international societies. Do you think at this moment there is equity in resuscitation training? How do we bridge the gap of having inadequate resources for some people? And how do we ensure that people all around the world are equipped to save lives?
It's a really good question. I don't think it's equitable at all. And we do know that there is a big disparity based on social determinants of health, not only for training, but also for survival outcomes. So when we are able to study it, we recognize that the penetration of equipment, training, response time, knowledge is disparate. And one of the fortunate things, I believe, is that the tools and the mechanisms to learn the essentials of life-saving first aid, life-saving CPR are very simple and not very costly. So that the likelihood is, especially with the evolution of the penetrance of internet, the penetrance of cell phones, WhatsApp, etc., that we will likely be able to reach many of these communities in a much less expensive and fairer fashion. And the other equalizer could be the telephone CPR dispatcher, because it may be that we don't have to necessarily get to every citizen to train them. We just have to train them to call and contact, and then many things can be done through that telephone dispatcher to be the help until help arrives.
It's really... Sorry. Yeah, our podcast is one way we were thinking of collaboration between different societies. And you guys at IELCOR are doing a brilliant job at collaboration and bridging this gap. And with that thought, I thank you so much for joining our podcast. It's been such an honor to have you here. I understand it's quite late in the Eastern times, but still you have joined us at this hour. Thank you so much.
My pleasure. Thank you so much.
Pleasure having you on the podcast, sir. Thank you so much for joining in.
Take care. And hats off to the Indian Resuscitation Council Federation.
Thank you so much.
Thank you so much, sir.
And that brings us to another episode of Resusc-i-Station. Until we meet again, goodbye, Godspeed.